Respected seniors and my dear colleagues, at the outset, I would like to thank Dr. Raju Vaishya sir and the organizing committee of JOO for giving me this opportunity. Today, I will be talking on the various research studies we encounter in orthopedic surgery and how it impacts evidence and ultimately patient care. Analyzing the number of papers in orthopedics using the following mesh terms on PubMed, we come across a whopping 730 papers. And if you look even more closely, this has been a logarithmic increase in the past 20 years of medicine. So nearly 90% of the publications in orthopedics have come in the past 20 to 25 years, showing that evidence and science is ever changing, and it is up to us to keep up in pace with that. So why do we have to do research? The most important aspect of why we have to do research is to contribute to science and ultimately benefit patient care. So let us take this case example of a hip fracture, a 77-year-old male, a diabetic who's had a fall, undisplaced valgus impacted hip fracture. Now, what is the best modality to treat this patient? Now, if this case is discussed, it's a very common presentation. I am sure many orthopedic surgeons will say we have to fix it as there is very minimal displacement, the mobility is less, they have good outcomes. There will be another group or a similar orthopedic surgeons with experience who say it is better to replace it. Now, both of them are not wrong. Both can be done, but which is the intervention which will give the patient the best outcome? This is where evidence and properly planned evidence comes in. Now, we all know this level of evidence pyramid, which most of us would have seen in many talks. As we all see, at the bottom of the pyramid is expert opinions, which people give mainly in meetings and out of their own experience. And as we go up from case reports and case series, then we have case control studies followed by well-defined and well-designed cohort studies of prospective and retrospective studies. And then we come up to the RCTs and finally culminating in the systematic reviews and meta-analysis. As we go up, the evidence is much better and the quality of evidence is much better due to the high impact of these studies and the way they are conducted. So let us see each level of evidence in detail. As we all know, case reports, these are just reports based on one case or two cases. And as we see here, it's an incidental neck of femur fracture. As case report implies, it's mainly based on experience based and there is a lot of bias. Now, it is very good and it's ideal for complex presentations and rare presentations or a very new intervention. But as you know, there is selection bias, there is experience bias, there is intervention bias. So case reports always have to be seen with caution, but it is a very good startup for anyone who is interested in research to get a publication which sets them in the research field. The next evidence is level 4 case series forming a group of patients, probably which has been taken after an intervention has been done, and about 40 to 50 cases which have not been categorized or generalized. As we all know, this is another form of level 4 evidence, as we see in this paper about a 30-day mortality, which is after the intervention has taken place. The biggest problem with case series are there is a risk of selection bias and there is no controls, and it's also more experienced and institution based. Now, case control studies, this is a higher level of evidence mainly aimed at analyzing the risk factors, as we see this example of how a sample population where if you have the disease, you are exposed to the risk factor and not exposed to the risk factor with a group of equally healthy cohorts or controls, and then you find out what is the risk factor intervention or not. Like, does obesity have an effect after total knee replacement? You take a group of patients and a group of patients who do not have the problem and then see, is it a risk factor? Like how this was seen in this study where they did a pilot study to find out the risk factors. So mainly these are observational studies aimed at analyzing risk factors. The next higher level of evidence are well-defined prospective studies. So these analyze a specific criteria prospectively, as they say, it starts and then you move on. So you know the intervention and you also define your inclusion-exclusion criteria, and thereby these are higher accuracy and higher efficiency studies. But this is not the best way for rare disease or studies which need long follow-up. The level 1 evidence or the most ideal treatment for any intervention or any analysis in medicine is the randomized controlled trials. Like if you see in this health study, which was published in the New England Journal of Medicine for hip fractures, you randomize patients whether they have a total hip or a hemiarthroplasty. The patient doesn't know what he's going to get. Even the surgeon prior to the randomization has no idea. So there is completely no bias. It's a straightforward investigation. But most importantly today, if you have to do a randomized control trial and if you have to get it published, you have to register it in the clinical trials or in any big forum so that you follow the ideal methodology and thereby you get the best evidence. So randomized control trials are the gold standard in treatment. Systematic reviews and meta-analysis, in a simple term, it's a review of reviews. You find out using an inclusion criteria or a specific criteria the best articles which you need to involve. Like seeing this article in the scientific reports, using their criteria, they analyzed 28 high-level studies and they got a whopping 31,427 patients. Now, no prospective study, no retrospective study. It will be very difficult for us to get so many patients. And as we all know, bigger data, better evidence. So this forms the highest, the top of the pyramid, the best evidence, especially when it comes to defining interventions. And of course, most of them, because of the volume and the analysis which needs to be done, there is always insufficient evidence, which helps us to define and then start an RCT in the question which is being asked. So why I put this slide is if you see in a Formula 1 race, there are about so many people working in a pit stop. So today in modern medicine, collaboration is the new competition. So do not do it alone. To get the best evidence, you need to collaborate. So once again, coming back to this slide, which is the best modality to treat an elderly patient with an undisplaced neck or femur fracture? How is the best way to answer this question to treat patients? We need to do a multi-center prospective randomized control trial, like how this fruity fix or replace trial of intervention, which is being done on a world level scale. And this gives us the best evidence of a well-designed multi-center collaborative randomized control trial. It gives us the gold standard evidence. And if we have to see in the big journals of the JBJS, the CORE, or the BJJ, which are the big three in orthopedics, or even bigger journals like the Lancet, as I already said, multi-center prospective studies are the way forward. Now, if we see in this pyramid, all studies have their pros and cons, but all studies are important, and it is important for us to define our goals and work toward it, and then contribute the best possible evidence for us in modern medicine. I thank you for your attention.